right. Welcome, everyone. Happy 2023, and welcome to the STAR Center's C-Suite Learning Network, focusing on leadership and HPET program financial planning. I'm super excited to have everyone here today. Real quick, since we will be on a webinar today, we are all way too familiar with Zoom after the past few years, I'm sure. But if you have any questions, please feel free to send them in a chat. You can send them either to any of our staff or just directly to Mariah Blake. Or if you're really having issues and the chat's not working, you can email her at mblake@clinicians.org, and we'll take care of any technical issues that you have. Other than that, this is a learning collaborative, and so we're going to all collaborate. There'll be some time in breakout rooms throughout this process. There will be times when we'll be talking through things or answering questions. And so we just want to invite people to participate. Whenever we have a presenter speaking, just make sure that you're on mute. I know we've all been there before where we thought we were muted and we weren't. So just make sure to be aware of that. But otherwise, we all know how this works. And so I hope this is a great productive time for everyone. We are here on behalf of the Association of Clinicians for the Underserved. And ACU is a nonprofit that was started over 25 years ago by alumni of the National Health Service Corps. And ACU works to support primary and other healthcare institutions, including health centers throughout the country. They have tons of different programs to do that, including a vision services program and a suicide safer care training program for clinicians and patients. And ACU also operates the STAR Center, which is the Solutions and Training for Workforce Recruitment and Retention, and that is our NTAP, our National Training and Technical Assistance Partner. And at the STAR Center, we are funded by BIPIC and the Health Resource Services Administration, and we are here to help all of our health center colleagues and provide free information, resources, and trainings and technical support to all of you. And so along with all of the resources on our website that you can check out, we also will schedule one-on-one technical assistance sessions. So please, if you need support with anything workforce related, do reach out to us. We have an incredible team here, and all of those smiling faces are ready to help you. And today we have most of the team on today, but specifically, I will be your host for today. I'm Alex Rolling. I'm a training specialist with the STAR Center. I use he, they pronouns. And I've been here about a year now, a little over a year now. And then also with us, we have Helen Ray Vernier, and she is also a training specialist, and she'll be running some of the sessions as well. And then we have Mariah Blake, making sure that everything technical actually works and that we're all able to be in this webinar together and use all of its functions, which is really great. Then we have today's guest presenter, Robyn Weiss. She works with the Northwest Regional Primary Care Association and heads the Education Health Center Initiative. So prior to joining NWRPCA, Robyn worked for the Northwest Region of Catastrophic and Complex Care at Rehab Without Walls Neuro Solutions. She also spent 8 years as an assistant professor of clinical physical therapy at El Paso, Texas. And there she helped to build the Grow Your Own model of PT, RN, and pharmacy, and sat on the board of their new medical school, the Paul Foster School of Medicine. So Robyn has an incredibly deep level of knowledge in this area. And so she's going to be kicking off our learning collaborative with a presentation today featuring some of the resources for the Education Health Center initiative and some of her experience around building a teaching health center and GME program. So we're really looking forward to that presentation. So our learning objectives for today is to understand what health professions education and training programs are and learn how those programs support recruitment and retention. Because some of the ways that they help with recruitment and retention, great, very obvious. Some of them may not be so obvious. And so we're going to explore a little bit of that. And then we're going to really get into the discussion of how do you build that kind of program? How do you build one from the ground up, or how do you grow and improve one that you already have? But before we get into all of that, we're going to do a little bit of a get to know each other exercise here. We want to know everyone that's here with us today and what your goals are for this learning collaborative so that we can really help you. So what we use is a program called Mentimeter, and any of you that have been with us for webinars or learning collaboratives in the past are probably familiar with it. But you can, if you have a smartphone, take it out and use the QR code that's on your screen there, and that will take you directly to the Mentimeter feature. Otherwise, you can go to menti.com and type in that code that you see on the screen, 4377-9893. And Mariah has put that in the chat if anyone needs the code. But once you're on there, you'll be able to answer some of our polling questions. And I will stop sharing my screen in a second here. We'll give everyone a moment to get that pulled up. And then I will turn it over to Helen to share the Mentimeter. All right. Terrific. So we're going to start with, if you don't mind, just share a little bit about yourself, your name, organization, your role, your time in that role. And I know some people may be newer to a role, but they have a large depth of experience relevant to that, right? So if you have greater experience, you're welcome to share that. And then if anyone wants to throw it out there, their favorite dessert. I like to start off sessions with something food related so that everyone's nice and hungry throughout it. That's my brilliant training strategy.
Especially cruel for those of us who are in mountain time. It's lunchtime.
It's
Think
lunch.
about a favorite dessert. Oh my goodness.
Yeah, terrible at being polite to folks in other time zones. I apologize. But Michelle says that her favorite dessert is always flan. I do like a flan. I like a nice tres leches. Or, just a good Oreo cookie and some milk. All right, and we have Denise Spurgeon with, I hope I said your last name right, Denise. And she is with Mosaic Health. She's been there for 4.5 years, and brownies. Oh, that's an excellent dessert choice. We have Joanne at Community Health Clinics, CFO 1 year, and then 30+ years in healthcare, and has been enjoying cheesecake for that entire amount of time, I think, from the comment, which, cheesecake's an excellent choice. We have Casey, who's a vice president of strategy and innovation for 2 years, another cheesecake fan. All right, 3 wins for cheesecake because Kirsten also enjoys cheesecake, is from Brownsville Community Development Corporation for 1.5 years. We have Ashley, who works with Hidalgo Medical Services in Southwest New Mexico. Been in that role for a couple of weeks, but have been handling their agency's student rotations, since September. Let's see, and Joan at Southwest Community Health Center, and project coordinator, clinical education coordinator for 4 years, but 40 in public health, including 11 at an AHEC in Connecticut. I remembered the state abbreviation correctly, right? That's Connecticut. And then, coffee ice cream or pineapple. Those are 2 good ones. I don't know if I'd combine them, but separately 2 good desserts. And let's see, Carolyn put into the chat, she is CEO at Charlotte Community Health Clinic since 2016. Oh, and cannelloni. Oh, that's a good one. Wait, cannoli. I'm sorry, cannelloni is a different thing. I apologize. I can't read today. We also have Kate at Mosaic Health, Director of Compliance. And she seconds brownies. Has anyone tried s'more brownies? You put marshmallows and graham cracker on top to make them healthier. Yeah, it's delicious. And we
Healthier, definitely.
Yeah. And then Susan, 3 years at as the compliance officer at the Texas Area Community Health Center, and coconut cream pie. That's a good pick. Oh yeah, Michelle backs up the coconut cream pie. Another one in the chat, we have Yolanda Finley from North Texas Area Community Health Center, and she's HR director for 4.5 years now. And another vote for brownies. We have Mike Leary at Mosaic Health CEO, 12 years on the job. Carrot cake is the only dessert. All right, a strong stance from Mike on carrot cake. Excellent. I do like a good carrot cake. That's one I kind of forget. My weird random one is lemon meringue pie. That's a like, when I'm like, I really want to go off the rails today. Good lemon meringue pie piece. Okay, and I think that may be everyone. Oh, we have one more. Let's see, Lisa from Mosaic Health as well. Been CFO for 13 years, 20 years at FQHCs, and good old-fashioned chocolate chip cookies. Excellent. And Danique Brown Smith, Charlotte Community Health Center, Chief Compliance and Nursing Officer, and pound cake. Oh yeah, pound cake. Dude, but pound cake with berries or just straight go nice simple pound cake?
I like cream cheese icing.
Ooh, oh man, I haven't tried that on pound. Okay, that's a new one to try on the pound cake. All right. Excellent. Well, thank you everyone, and we'll jump to the next slide, but feel free to put in the chat if we missed you. And then I just wanted to get a feel for, does anyone have experience with HPET programs? So like if you've been a clinical instructor or helped work on a curriculum, or you can say none if that's your level of experience, that is totally okay. If you've done some other facet of the planning or execution for an HPET program, just let us know. All right, we have one in the none camp, two in the none camp, three. All right, four. I should have done this as one of the little scales, but. All right, so quite a few folks who are coming into the game ready to learn, fresh, no preconceptions. I can't say that, I guess, but yeah. Okay, business and admin support for graduate medical education is GME for anyone. And if I throw out an acronym, I try to like say them, and we're going to go over what HPET is, but if I use an acronym without explaining, please let me know, correct me. I am constantly there with like, what does that acronym mean? Someone says no HPET specifically, but professor for master's and doctoral program at Rochester School of Nursing. Cool. No experience whatsoever. Excellent. That won't be the case by the end of this. A few months you'll be like, I've got some knowledge. It's not my first rodeo. Okay. And again, you can throw into the chat if we missed you, but we'll jump on to the next slide here. So what are you and or your team's HPET programs or plans? So if you already have a program in place, or if you're planning on doing something, or if you haven't even gotten that far yet, that's okay. What do you hope to accomplish with some sort of HPET program? So some sort of health professions education and training program. Okay, so we have potentially starting, a CHW training program. Awesome. Getting some community health workers. Okay, developing a curriculum for medical assistants and dental assistants. And another dental and medical assistants, having a training program for them would be great. Good. Improving the program and formalizing some of the systems. Yeah, so it sounds like maybe you have some staff development systems already in place, but you want to get a little more formalized with it. That's excellent. And throughout this entire learning collaborative, we are going to talk about that whole range. of kind of training opportunities, right? Because we have everything from training community health workers on up to running a graduate medical education program like a residency, right? And so we're gonna, over the next 6 months, cover all of that. All right, and yeah, we'll go ahead and jump to the next slide, but feel free to keep typing it in or to put it into the chat. And then, do you have any people, any subject matter expert, or any resources that you consult for information and support with regards to HPET? So did you check out some resources before you signed up or joined this learning collaborative? Or, I mean, it could just be someone at your health center. You could say, Dale. But you could say like, oh, we have someone at our health center who's done it before, and we've been talking to them. Or, are you looking for resources? Is this your first step on finding all of that? Helen's a big fan of Dale. Dale's useful, knows everything about everything. At a former place of employment, we had Stan, who worked in the warehouse. So we called him Stan of the warehouse. And he was your go-to. If you needed tissues, he knew where the crate of those was. All right, let's see, in the chat, we have the National Oral Health Association. So NOAA, that's a good resource. They have some good stuff. Yeah, so some folks looking for resources as well. And we're going to provide you with a lot. Robyn has a ton of resources in her slides, and so we'll get to her presentation shortly, and she's going to give you a ton of great information to start from. All right, and we can probably go to the next slide, I believe is the last one. All right, so what is one thing that you hope to gain from the Learning Collaborative? And it can be something just related to your personal knowledge, or are you hoping to use this as a springboard to fully starting an HPET program, or is it somewhere in between? All right, knowledge and building a network for assistance, excellent. I think we can fulfill that. Okay, how to set up a program. All right, and we have in the chat, we have knowledge. So just knowledge in general, excellent. Preceptor training ideas, organizational knowledge for the team, terrific. All right. Roadmap for new program development. Okay. Assess the viability of building your own program. Excellent. And I think in just a moment, we'll jump back to the slides, but feel free to continue, finish putting in an answer if you would like. And I appreciate everyone's like ready to participate. That's terrific. Because yeah, as someone said, that knowledge and network for help, we want all of you to be resources for each other as well. So we're going to give you a ton of information and knowledge, but then we want this to also become a cohort that you can all continue to work with each other even after the completion of the Learning Collaborative, and support each other with resources or insights, anything that you discover along the way. And and we have assessing students as potential employees. Yeah, that's a big part of the recruitment aspect of an HPET program. All right, well, I think we will jump back and let me get my slides back here. Terrific. Is that good? Looks like I'm sharing the correct slides. Perfect. All right. So health professions, education and training. So this is what HPET stands for, or HPET. And this can be everything, like we say, clinical rotations or training. You know, as we know, pretty much anyone in medical care at some point has to get kind of supervised experience performing the hands-on skills that they're learning, right? And so this can be, like we said, everything from training up community health workers, medical assistants, dental assistants, those sort of folks, on up to, you know, nurse practitioners, PAs, medical doctors, you know, RNs, LPNs, all of these medical staff have to have clinical hours. There's different requirements and everything around that. But any kind of program that you are a part of or supporting or running on your own, that's what we're going to lump into HPET programs. And we want to remember that this can also apply to staff that are still in the medical field but may not be clinical, right? So if you have like medical billing, right, like those folks need to learn, and you may be able to work with, say there's a training program at a technical college, and get them some more experience or information on what that job really looks like in real life, what specific systems you might use, and to get them some more of that real world experience. And it also helps with recruiting those staff. A real quick note, I have certainly used the term pipelines to refer to avenues into, you know, careers or certain positions. But it was brought to our attention that the National Congress of American Indians, so a group representing indigenous people in the United States, do not like the term pipelines, and their recommended term is pathways. And I actually really like the term pathways as well, because it implies more kind of options instead of like, we are forcing you into this avenue. It's like you have many choices, you have many pathways to get to different career options. So that's what we are using the term pathways for, is just any of these routes through education, either on the job or more formalized, you know, academic setting education, into different job opportunities. All right, and why is HPET a really good tool for recruitment and retention? Well, there's been studies that show that practitioners are going to stay in the areas where they did residency. But, you know, more broadly, just it allows you to turn that community into a pool for recruitment, especially with some of these programs like an MA program, where you could take someone who may not have a ton of, you know, high level or formal education, but you can provide them the tools to build a successful career, to get into the world of medicine. And you can do that for pretty much anyone in your community, right? There are even MA apprenticeship programs that operate in conjunction with high schools. So you have high school students going in their last couple of years and building these skills to go out and get employment. And later on, those people may have developed an interest in medicine and go on to be nurses or doctors, or work in other areas within the health center, but you've built that pathway, that way for someone who might not normally be able to get that kind of education and skill-based training, and allowed them to get that and allowed them to come into your health center. So that's the really big thing that HPET helps for, with both recruitment and then with retention as well. So, right, we see with recruitment, we can introduce people to the idea of health centers and working with underserved populations, developing connections, right? You can see, oh, this person like is really great, they're really motivated, they'd be wonderful to have on staff. Let's make sure we reach out to them when they are done with their training program. Make sure they know they can come work here if they liked it here, right? They're already halfway onboarded. They've done some rotations at your health center, so they kind of know the deal, know the people, and everything. But then also retention, right? And we don't always think about this side of it, but a lot of people like to teach. I think almost everyone likes the idea of, oh, I can pass on some of my knowledge and experience and help someone who is earlier on in their career, right? And so giving people that opportunity can really increase job satisfaction, right? It also makes us hone our own skills. I know that I have been in teaching roles before where I was like, oh, I really need to brush up on these skills, because I need to not just do them, I need to be able to explain them and walk them through step by step. And it makes you better as a practitioner when you are also teaching and training and continue to stay on top of new developments, because these students come in and they have the most up-to-date training and you got to stay up with that. So it can also improve the quality of patient care, right? People are going to be really on top of their skills, and they know that they are setting an example for learners, right? And then you can also, through building some of these partnerships with other institutions, you might be able to gain potential perks for preceptors like additional opportunities for CEUs, extra training, access to academic libraries, things like that. And then you also build kind of that team solidarity, right? We're all working together to train these students, these learners, or train other people who already may have a full job in the health center, but are along a career pathway, right? And are going through some of that employee development. So it can really be useful for retention as well. I also want to real quick let you all know that we understand that there are kind of a need for realistic expectations and an understanding of the context, right? Not everyone can just jump in and do everything at once. So we're going to, at different points throughout this Learning Collaborative, talk about the staff time commitment and how to understand that piece. Looking at, partnerships. How do we build partnerships with other organizations or within the community that are going to support us? Accreditation, getting buy-in from, a lot of you are leadership, but if you have other leadership who may not be bought into the idea, how do we talk to people and like really make it clear this is a good opportunity? And how do we make sure that it is the best opportunity, right? How do we avoid the pitfall of getting drawn into a partnership that may not be helpful versus finding one that really helps us do what we need and we can help someone else do what they need and have that win-win. So we're gonna discuss all of that and try to keep a very realistic approach in mind, that everyone's context is different and what works for everyone is going to be a little bit different. But with that in mind, I'm going to now turn it over to Robyn, and I will let her bring forth all of her vast knowledge.
Or something, huh?
That's gonna be great.
By the way, my favorite dessert is I'm a connoisseur of really good ice cream. So that's, if we're going out, I love those little boutique shops now that are popping up with the really good ice creams. That's my favorite. Okay, so let's go ahead and get started. So first of all, that big old acronym right at the top there, that stands for THCGME, is Teaching Health Center Graduate Medical Education. So what I'm talking about today is just sort of it's an overview of the program and sort of those financial considerations that need to be taken into play. And if you'll go ahead and go to the next slide, I've got a couple of disclosures I have to do here till, before we can get into it. One of them is I will be talking about the THCGME program. And this is just a disclosure from HRSA about the endorsement and official views and all that good stuff. So let's go to the next. And here are my objectives, just sort of honing in on my portion of it. It's really to understand why the work of the Teaching Health Center Graduate Medical Education Program is important. It's an overview for the understanding of what residency training costs and financial risks are. And for that part, I am going to be giving a lot of resources. So those are things that you all can dig into and find. I've kind of gathered things for you that you can dig into and share out as much as possible. Network with people would be great. And then the third one is to talk a little bit about the EHCI guide for THC development, knowledge, and resources. And that stands for EHCI is the Education Health Center Initiative, which I will come back to in a moment. And THC again is Teaching Health Center, which I have misspelled there. Nice, I'll have to fix that. The mission of EHCI is to improve healthcare for the underserved populations by helping community health centers and state primary care associations really develop that innovative workforce training partnership for urban, rural centers. And it's a way in which we can really just connect with folks, share ideas, and help develop a network. So let's go on to the next. Graduate medical education, GME, why is it important? And we've already talked a little bit about pathways. We've talked about how building this program within the community health center really helps the residents cement their ideas that they want to stay within a community health center. And that, the quote was that it's twice as likely that they will stay and pursue medicine within a safety net setting. That's what we want. In the national and regional projections of supply and demand, we all know this, primary care physicians and our workforce is, the need is growing. And when I talk about primary care physicians, I'm going to lump in primary care physicians, internal med physicians, psych, OB, pediatrics, and dental. That's all going to be within what I'm talking about today for this GME or the Teaching Health Center workforce initiative. And we'll go on to the next. So to start this off, and I'm going to be pretty brief, and the reason I'm going to be brief is there are actually folks out there that spend their lifetime just getting into the weeds of the numbers and the formulas and the direct GME funding versus the indirect medical funding. So I leave that to them. What I'm here to do is give you a brief overview so we can have this financial discussion, but also to pass along a ton of resources so that if you want to do that deep dive, you certainly can, and I'm giving you the resources to do it. But just sort of a brief history of GME funding, graduate medical education funding. It really started out being completely funded in the 1960s through Medicare. And back when Medicare was really funding this, there weren't a lot of checks and balances. It really was what the hospital cost training needs. They'd put a budget forward and Medicare would sort of fill in that gap. So there wasn't a real consensus look into what was going on with that Medicare funding for the GME training programs. And these were all hospital-based training. In 1983, Medicare put into play the PPS, which is the prospective payment system, and it really broke apart the GME training, the funding, into two different streams. It was the direct GME funding, which was only about 30% of the funding, and the indirect funding, which was that, the bigger part of it, which is the 70%. And I have another slide that kind of breaks that down a little bit more. But from there, but it still kind of was an open stream. It really wasn't, there were no end caps to the funding. And it was, again, all going to hospital-based training systems. In 1997, the Medicare support of the GME was relatively still open-ended, until we hit that Balanced Budget Act. And that really put a stop to that just kind of flow of funding for these hospital-based residency programs. The support was capped, and it really created an reallocation of funds. And for the first time, sort of in the 1997 era or into the beginning of the 2000s, other hospitals were looked at, and the allocation of funds were then finally sort of redistributed to states that really needed it. And what they looked at mainly was the lower physician numbers for the population ratios, meaning access to care. Access to care became a focal point of how are we putting these fundings together, and are we making sure that dollars are spent in areas where access to care is more of a problem. Let's go on to the next slide. Okay, so again, just a little bit of overview on that, on how the Medicare dollars were split. Direct expense factors were again about 30%, and indirect were about 70%. Direct are really actionable items that you can put a dollar amount to. What are your faculty costs? What are your residence costs? Administrative costs, malpractice insurance, clinic operations. These are a little bit more concrete numbers, but the 70% of the Medicare funding went to those indirect expenses, which again, were kind of all over the place. It was really trying to decrease the gap in the funding stream where preceptor productivity and billing had to be decreased. They couldn't see as many patients because they were doing the training. Or if you're involved with residence programs, test ordering just really increases when you have residents. There are more labs asked for. There's more EKG scans. There's more CT scans. Residents tend to be a little heavy-handed with the testing, and that really can increase your funding needs. Longer hours, increased teaching time, lower resident to patient ratios, so not overloading the resident the way we can overload some of our seasoned physicians out there, and then just trying to mitigate the cost of any errors related to training. And again, to do a deep dive on this is not really warranted in this particular talk, but I've put in all kinds of resources for you if you want to do a little more look into payment programs. And we'll go on to the next slide. Okay, so this is a really interesting slide, and it may kind of shock you at the cost up there, the median expenses per resident per year, and it takes in all these factors. So to train a resident per year, we're talking about their compensation, the faculty compensation, clinical administrative, clinical operations, and other educational expenses. Now, this study has just been redone, and it's out of the George Washington University Milken Institute for Public Health. It was a project that was done just recently by Marcia Regenstein with GW, and it just came out in 2022. So what this is saying is, and it was really important that this work was done to sort of bring up that cost base so that reality is in place if you are putting these programs together, because back in 2017, these numbers were down in the 157,000 range. So we can see the cost has gone up quite a bit. Now, this is a range, this is a medium. And as the THC world, the Teaching Health Center world has matured and we have more programs on, we get a little more accurate of number base. But in particular, if you have a smaller program or you're in the 25 percentile of what you're trying to push out for THC, the numbers can go down into the 175,000 range, but can bump up into the 263,000 range. This is a medium. And again, these, go ahead and go to the next slide. I can get you more information. I don't know, do I have a link? I do have a link on there. Okay, so you can look at how the investigation put these numbers together. You can see really how they're developing their model for putting this together, so you can have a little more understanding. Go to her information, go to some of these other resources that I've given you if you really want to do more. There's some financial people on that are like, I need more information, go for it. Just open your heart up to all these numbers. That's good. Now, so this one is really talking about the median revenue. So as you can see, we have a big gap into what a resident is bringing to the table as far as revenue for patient services versus what the expenditures are for a program. So this is something that you've got to keep in mind if you are developing a program. Now, how do we go ahead and mitigate the costs? Let's go on to the next slide. Oh, if you want to do a little more deep dive into program payments, this is a great link to go ahead and do a little more investigation. Just wanted to put this in. And we'll go on to the next. This is all about funding formulas and all of that. So how do we go ahead and look for other sources of funding to eliminate that GME gap? And again, before the 2000s, we really had sort of these open checks being written from Medicare to go ahead and put in place the funding for GME. That's no longer the case with the Balanced Budget Act and some other caps that have been put in place. So where is the money coming from? So a lot of you might be familiar with your state Medicaid, not Medicare, but Medicaid programs that are doing direct funding for GME. These are going to be state programs, and they are going to range in the funding that is allowed to go to GME and how their formulas work. do a deep dive into your state, see what's out there, see if you're one of the states that's still going through sort of a Medicaid reform program, or whether you have a solid GME or even HPET workforce program that's offsetting costs. So that'll be work on your end for state programs. There are state programs out there that are just phenomenal as far as what they are giving to the GME program to keep training residents for their state. Now, we also have HRSA. HRSA has come onto the scene into the development of the Teaching Health Center, and they have really upped their game as far as funding dollars for things such as planning and development grants, the THC GME expansion grants. We also have the National Health Service Corps, which has some funding for GME, Children's Hospital GME, which is specifically for keeping those children's hospitals training programs going so that we have good pediatric physicians going into programs. We have other health profession programs, other state funding, and the VA. Let's go on to the next, and I'll give you a little bit of a kind of a model here. It's a little bit hard to understand, but if you look at the very top, and again, I give you links for everything. If you go on to looking at payroll tax, insurance premium, other revenues, we can see that a lot of that is funneling down into Medicare. Medicare is still the main GME funding source for our teaching hospitals. Money goes straight down from Medicare into teaching hospitals. Now go on over to the side here, and you can see these other programs that are really in the know or into the mix of funding teaching health centers, but now for community-based training sites. This is the first time since that Balanced Budget Act and the monies were reallocated that we are really taking a look in GME around access to care. So community-based training sites for residence programs for family medicine, internal medicine, the pediatrics, the dental are now being funded in community-based training sites. The Department of Defense, the VA, HRSA, all have allocated state funding through Medicaid, all are funneling down into these community-based programs. And next slide. Okay, so Teaching Health Center funding. In 2011, the Affordable Care Act created the actual program of THC GME support, and it expanded to primary care medicine and dental residency programs into what I was talking about, this community-based ambulatory patient care center, mainly those CHCs that we're all familiar with. The residents are funded by HRSA over current physician training caps, which was the Medicare programs. Many of the patients may not have even had treatment had this program not existed. So we are now able, through the residency program, through these teaching health centers, able to really work solidly and have our hands in access to care. And this is phenomenal. So 2011, this really took hold. Most of the teaching health centers are federal qualified health centers, rural health centers or health clinics, and tribal health centers. So the priority care for high need communities and really working with the vulnerable populations. Next slide. Teaching Health Center Graduate Medical Education, or THC GME, who benefits? So we've talked a little bit about, there was a quote there that when a resident is training in a community health center or a vulnerable population access to care program, that they're more likely to stay. And that's exactly what we want to really push out. Over half of the THC GME program training sites are in these medically underserved communities. Training in these communities increases the healthcare services and adds more primary care workers. So if you are talking pathways, that's exactly what we're trying to promote. It's taking on those residents and keeping them, really getting them cemented into the mission of the work and keeping them in the health center world. Even if, our hope is that even if, they're trained at one health center and they have a move, that they are looking at going back into community health centers first before they're looking at any other job opportunities. Since the 2011, the THC GME program has supported and trained over 1,700 new primary care physicians and dentists. There is a link there that is just wonderful information on what's happening currently in the program. Let's go ahead and go on to the next. So with HRSA pushing out all of this new funding, we have just expanded the model like crazy. It's just wonderful. And actually, there is a grant for the planning and development, which I'll talk about in just a moment, that just ended, and new teaching health center planning and development grants, as well as expansion grants, should be announced here nationally. New programs here within the next month. We should hear some of the new programs that are being funded by HRSA. So there's a link to this program, but we, THC GME residents treat over almost 800,000 patients during more than 1.2 million patient encounters across all settings, significantly enhancing the access to care in primary care, family medicine, internal medicine, obstetrics, dental, pediatrics, and all in those underserved areas. And next slide, please. Here are the cohorts from the first planning and development grant for building a brand new THC or expanding services into a new area for Teaching Health Center. This was the first cohort. So these came out last year. And you can see here that some of these states, it's their first one. It's their first teaching health center that's going to be within their state, trying to up the number of residents that hopefully will stay within that state and the community health center in which they are training. So this is wonderful stuff. And go on to the next. So the THC GME program had a couple, the very first cohort that came out last year had a couple of different grant opportunities. We had the planning and development grant. We also had the expansion grants for teaching health centers, but they also enacted for the first time a brand new TAC center, or technical assistance center, that is housed mainly at the University of North Carolina. Now, University of North Carolina, probably one of the reasons they're just really on top of all this is they are also the technical assistance center for the rural track development. And now they are the TAC for this new, now the two cohorts of the planning and development grants, and they're doing a fantastic job. One of the first things they developed was this roadmap. This is a roadmap for teaching health center program development. But I want to emphasize that kind of from now on in my talk, now that we've gotten through all the funding and all the historical stuff, this can be used for almost any model. You can take an awful lot of what is being put out here or in the guide that I'll introduce in just a moment and use it for almost anything. You want to put in MAs. You want to do a program. Arkansas did a fantastic program on LCSWs, where the state was getting involved with putting out a training program to put LCSWs as training, as residents, basically, doing rotations in community health centers throughout their entire state. It's kind of the same formula. Maybe the residency program is a little above and beyond in some places, but the model's the same. So you all can use it in HPET for almost any model that you want to push out. Nursing, PAs, MADA programs, CHW, the list goes on. So the model is the same. It's just a little more complex with residents. But this is a great roadmap, and this is available for use through the THCGME.org, which is that tax center out of the University of North Carolina, HRSA funded. And next slide, please. Okay, financial considerations for THC GME development. Now, again, keep in mind, a lot of this information might just be for other models that you want to do, but things that you got to ask yourself, if you really want to go, if you're a health center that has already been doing shadowing, which is where a student really gets the idea that they want to become a doctor and pursue medicine in that way, whether you're shadowing PAs or nurses or potential residents, shadowing programs, and then going to clinicals. If you are an HC that is really involved with the medical school in doing clinical rotations, wonderful. Or you want to go ahead and up your game and become a accredited THC program through the AAC GME program. These are some considerations. So a first consideration is just what model is being pursued. Are you a new program or are you going into expansion? So for instance, we have through this last planning and development, or even the new one, we've got some great family medicine THCs that now want to go ahead and do a residency program in pediatrics or do dental or do psychiatry. So that's going to be an add-on or expansion program. And of course, additional funding, because you're going to have more preceptors, more admin time, all of that combined. You also really want to look at your planned source of funding. Are you going strictly through HRSA, THC, GME, or are you looking at that CMS model for access through the Medicare programs? You also need to look at hospitals that will actually host your rotations. So even though your residents are doing a majority of their work and bringing in some revenue to your CHC, they also have to do hospital rotations. They've got to get in their surgical. They've got to get in their OB. That's huge. They have to do so many deliveries, so many C-sections. So you have to have that hospital that will host your rotations, but you also have to be careful that they don't take over your program. It is rooted in the CHC. In your hospital, you want to look at whether you're doing acute, community, critical access. Do you need to have 2 hospitals to get that obstetrics rotation in there? So all things to consider when you're looking at your community. The next one is how accurately to develop a model to measure capacity. Will the reimbursement rate at the CHC keep your program afloat? Is there revenue? How is that tracked? And, you know, there are models out there that are actually turning a profit. And that has to be tracked and reported, because every dollar that's over your gap has to be accounted for. And that's just a whole nother level of administrative costs in the financial reporting. And then you need to look at your startup costs. So startup costs to actually do a THC, they're hefty. They can actually, in general, startup costs can be around $300,000 to, if you're doing a larger program or you're trying to do 2 expansion models at a time, can be quite hefty. These all take into account your sponsoring institution, your director of operations, your GME administrator, other administrative support, legal, accreditation fees. All of these get lumped into startup costs. And how is that being funded? Again, there's another link at the bottom, really good information for startup, and also that roadmap, really good information for doing a startup if that's what you'd like to talk to your C-suite or your board about, you know, hopping on board this train. Go ahead and go to the next slide, please. Okay, so what we have done through the Education Health Center initiative is we put together a guide. And that is one of the biggest takeaways that I'm hoping you all can not only take back to your CHC, but also share. If you know somebody else, you meet somebody at a conference and they're thinking about this guide is fantastic. And again, keep in mind that a lot of what we're talking about can be used for other programs, not just THC residency building. So there is a link to the guide. I have another link later on. The EHCI is definitely a partnership of the CHAMPS region as well as the Northwest Regional Primary Care, those two coming together to put this together. And we did have significant HRSA funding, as well as the Macy Foundation helped us put this together. And let's go ahead and go into sort of the meat and potatoes of it. Next slide. All right, so this guide, again, free, accessible, and it can be, the different sections can be taken apart or used together comprehensively. You can use them for other programs. This is designed mainly for that residency training program that we're hoping you all will look at and want to build or support in some way. So the 5 key areas: overview and mission, the governance, how to get this thing started, administrative and operations side of things that you might not have ever thought about are going to be listed in this guide, financial and legal, very important. And let's go on to the next. So the Education Health Center Guide resources, the very last section is something that I really want to draw your eye to. There's a link up there in the corner to get to the guide, but these resources are invaluable. We go through many of the different resources within the guide, from statutes and regulations to the Education Health Center initiative resources, health resources services or HRSA resources, NAC resources, and of course, the all-important Accreditation Council resources. So this is really that meat and potatoes of the entire thing, to where you can just, go in, answer questions, form new questions, which undoubtedly, whenever you're trying to answer one question, you come up with 5 more, right? But it really helps to get you a footprint in THC building, what it's going to take, what the finances are, and how you're going to put this whole thing together. So I highly, highly recommend just trying to download this guide and just use it for whatever you can. Again, it's a HRSA resource overall, but it will give you a lot of nuts and bolts to how to figure this thing out. And I think that is it. You want to go to the next one? So EHCI, please contact me if I can be of any additional help. I've given you a little history of where the funding is and a little more information on where it's going. And it is, my belief, NWRPCA belief, is it's here to stay, that we are really looking at continuation of funding for GME products, for THC, the Teaching Health Center world, whether it's going to be in expansion or supportive funds, or whether we are going to have another round of the planning and development grants to be able to get new programs off the ground with their SI, their sponsoring institution, or even just doing their apps. These are all things that the EHCI can help with. We dive into and support grant writing all the way down to actually doing those applications, all the way down to doing site visit mock-ups and presentations to get the health centers ready for their final accreditation step. So we have a big footprint in a relatively small program if you look at the world of teaching health centers or GME, but it is such an important piece in making sure we have access to care, making sure that we are doing our HPET initiative and having pathways to success, keeping the residents that we're training really rooted in the mission of the teaching health centers and the community health world. So that's what we're all about. And if I can be of any help or assistance, please reach out. No question is too small or too large. And that's really my presentation today. Do we have any questions that I can help with, or anything I can clarify? And I can't see the chat, so.
I was to say, feel free, anyone, to put questions in the chat and I will relay them, or you can unmute yourself and ask if you have a question for Robyn. And while we're waiting on that for a minute, thank you so much, Robyn, for all of that information. I read through the EHCI guide and it is comprehensive. It is like a wealth of information.
You know, and even if you just go to that first page and look at the folks in the THC space, GME space that helped us put that together, it is it's the folks that have all of this wealth of information, and we were able to capture that and put it into one comprehensive piece. So it's you know, this is sort of a reenactment of the guide. There was an original guide from HRSA. This is sort of version 2, and it's way more up to date, way more into the complexities of what it takes to build a program, whether again it's residency or you're looking at doing a PA, RN, whatever it may be.
And I also looked over you have a spreadsheet that goes with it for the financial planning side. And I looked through that, and I'm going to make sure that the cohort gets access to that, because it's on the EHCI website, but I'll make sure everyone gets a direct link as well, because anyone who's planning on building out a residency program, that's a really fantastic resource to have.
Yeah, absolutely. And also, you know, not only can you tap into the guide if you have additional questions, but also take a look at the thcgme.org site. It also has quite a bit of resources, and this is a tax center that is specifically designed to help the HCs that have gotten that planning and development grant through HRSA to just keep them on the pathway to success. So there's advisors and mentors and workshops and all kinds of things. So if you decide you want to take that leap and get in, there's a lot now, more than ever, there's a lot of support behind you to make sure that you are doing it right, you're successful, and we're helping to build programs that will be sustainable. That's the biggest piece right here. Is we know it's hard. We want to make sure that you have as much sustainability for your programs that you're putting together as possible.
Excellent. Well, and if anyone thinks of a question or whatever, feel free to ask it. I'm going to jump through. We have a few more slides.
Absolutely. Thank you.
And thank you so much, Robyn. And her information is on there. You'll have access to the slide deck after the presentation. So all of the links that she had on there, you'll be able to access, and you can email her or any of us with questions as well. And just to move on real quick. So throughout the Learning Collaborative, we're going to talk about we're going to really focus on the financial assessment piece, but kind of the general assessment part as well of what kind of program is going to work best for your context. You know, like we talked about earlier, it is kind of context dependent. What's going to help your health center the most? And so when you're trying to come up with that, one of the things that I have done a lot of work on over the years is how do you put together a plan and do those kinds of assessments of, I have to accomplish this goal, so how am I going to figure out what I need to do for it? And you know, one of the things you want to know is just what program is going to be of the greatest benefit to my health center. It doesn't really help you to build a whole MA training program if you have plenty of medical assistants, and what you really need is clinical social workers or other mental health workers, right? So you want to really figure out what plan is going to work best for you, and then what internal I said Reese's as well. It's the Reese's peanut butter cups are just on the mind today, I guess. But what internal resources do you have to support that? So staff that are capable of and interested in teaching, you know, facility space. You know, do you have enough facility space to take in learners? And you know, do you have people who are experienced with teaching? Or are you going to need to do some kind of train the trainer type work? Do you have adequate staff to cover for the time that's going to be taken away from staff doing clinical work when they're going to be doing teaching work, or just seeing fewer patients because they're guiding learners through that process? So think about those external resources. What partners do you have in your area or in your region? What resources does your PCA have? What resources, like Robyn and the EHCI team, do you have that you can reach out to get really specific guidance? Financial resources, right? Like HRSA funding, state funding. What kind of revenue does your health center see? And can you calculate out what it might see if you take on learners? And then also timeframes. What time frame do you have to work in, and what problems do you need to solve now versus what challenges can you put together a coherent program to address in the long term, and what kind of timeframes what those timeframes are going to do to that long-term outlook. So what are the trends in provider availability, right? Because we can look at some of that data and see like, well, the need is probably going to outpace the number of healthcare workers in, several different really critical fields. And so maybe where should we start focusing our efforts now so that we don't end up with that scarcity of providers later on. So things like that. And some of the ways we're going to do that, we'll be sending you a link to some coursework that'll be on the discussion boards, and they're going to include some tables. And those are just guides to help you start with this assessment. So if you're looking at over the past several years, kind of looking, did we have staff roles that were especially vacant, especially hard to hire for over the past several years? Have we seen, kind of a trend? So if you're starting to manage a lack of staff, then maybe there's another area where an HPT program would suit your needs better. But if you're seeing more and more scarcity of, say, RNs, say you just don't have very many nurses that you're able to retain at your health center, maybe we need to kind of focus on that for HPT program. Or staff roles with the longest time to fill that vacancy, right? Generally providers, right? It could take a long time to fill a family medicine or an OB position or something like that. So maybe that's where we need to focus our efforts. And then the staff shortages with the greatest impact to operations. Again, if you have a bunch of PAs working at your health center, but you don't have enough providers to provide, provider for them to work under their licensure, depending on your state's, regulations about what PAs can do independently, that might really hamper your ability to actually use that other resource. So you might have a huge impact. If you have no dental assistants, that may slow down the progress at your dental clinic, because the dentist and the hygienist are doing, all of the work instead of focusing on their roles with adequate support staff. So you can really look at these things and start to think like, oh, what's going to provide the greatest impact for the input? And then when we're looking for data sets we can use, on this slide, you can see that first of the green tables down at the bottom says notable trends in provider or other occupation numbers. That UDS right there, that's a link. So when you get the PowerPoint, you can click on that, and then it'll take you to some of HRSA's data sheets, and you can see on them, they're pretty interactive. You can look and see trends and predictions in the trends for different provider numbers versus demand. And so this is a really useful tool for kind of thinking like, oh, what shortages might we be facing in the future, or might get worse in the future? And how can we kind of head that off and think ahead? Maybe we can, start thinking about how to get a residency program going, or a partnership with an already extant residency program to help fill some of those positions that we think are probably going to get harder to recruit for in the future, right? And then you're also going to want to look at those internal resources that you have, right? Staff expressing a desire and an ability to help teach, help train, and then also staff who might want to receive more training. You might be developing a program that's more focused on internal development, taking some of those staff, and kind of building up their capabilities or their capacity internally as well. And so that's also a resource and an opportunity you want to be aware of. So these tables, you can expand them out. You can add, more to them. We'll be giving it to you in a Word document. So you can really kind of make this your own and make it work for you. And that's part of what we're going to be doing over the course of the Learning Collaborative, is really building this plan that you can then work from to start building out your HPET program. And you can use it in conjunction with resources like the EHCI guide, anything that suits your needs. We want you to just be pulling stuff from everywhere and really making a plan that's specific to your health center's needs. And then a little piece of guidance that I did not come up with. I definitely have stolen this from other people more knowledgeable than me. But one thing that I really like to kind of keep myself on track when I'm doing an assessment of something is what's called the resource equation. And it's just resources minus requirements tells you whether you have a surplus or a shortfall. And when we're thinking through what we do with that, that's kind of how we create a plan, right? We have to figure out what we need, so what our shortfall is, and then how do we get what we need using what we have. So in other areas where we may have surpluses, that may be something we can contribute to a partnership. Like, hey, we have a really, like, medically diverse patient population. That is a surplus that you have that you can share with another organization that's looking to get people training in a really educational environment, right? An opportunity to see lots of different patients and see lots of diversity in care. And that's actually a huge resource that I think is often overlooked when people are starting to reach out and make these partnerships. So keep kind of all of that in mind when you're building your assessment. And later on, we'll talk more about kind of building partnerships and then how we assess the training programs, especially the costs associated with building out different types of training programs. And then, of course, the really important learning and improving piece, because these are all going to be kind of iterative processes. You want to always be evaluating, how can we make it better? How can we make it suit our learners a bit better? How can we support our staff better in doing it? How can we make this program improve patient care and quality of care as well, right? So we have a bunch of other resources to go along with Robyn's, and some of them will probably overlap. Hers were really comprehensive, but for all different types of programs that you might want to start, there's all kinds of resources. We have the different accrediting bodies, right? Because accreditation is very important for a lot of programs. There are some, like community health workers that are going to vary state to state, medical assistant as well, whether they need to be licensed or not in the state, kind of depends. But you have ones that are national, so like nurse practitioners and, doctors and all of these. And so these are the different accrediting bodies. And then also information and support from other organizations that can help you with that. So all of these, I won't go through each one. These will be on the slides that you can go back and reference down the road once you've really done that assessment and decided, oh, this is what's really going to help our health center. We're going to build this GME program so that we can get more residents in. And then for the final 5 minutes, Mariah is going to put you in some breakout rooms. And if you would just introduce yourselves to each other and kind of talk a little bit about what you might be able to help your fellow learners with and what you would like help with as we go through this program. And like I said, we'll just be in the room for about 5 minutes because I don't want to hold anyone too late. And then we will wrap up. But before we break into the rooms, I just want to tell Robyn, thank you so much one more time. That was really incredible information. And she is a terrific asset. So I really do recommend checking out all the EHCI resources and reaching out to Robyn if you have more questions in that realm. Thank you so much. Welcome back, everyone. Sorry, I know we are running just a couple minutes over, so I will wrap up here real quick. But I wanted to make sure everyone got a couple minutes to kind of introduce themselves to a few of their colleagues, and we'll do more longer breakout sessions as we go through the Learning Collaborative here. But then on this slide, when the slide decks come out, you'll be able to find them on the discussion board. And there's a link on here, and we'll also email out a link to the discussion boards and make sure that you have them. And that's a place where you can speak with each other. It's just like any other posting board, so you can write messages and ask questions or discuss back and forth with each other. But that's also where you can go to find the recording of each session, the slide deck in PDF form, and the coursework. And so the coursework, like I mentioned earlier, is going to be a Word document with those tables and a little bit of guidance on kind of how to fill them out. And it's just kind of starting to get the feel for assessing what type of program is probably going to fit best with your needs and resources at your health center. And obviously, if you have any questions about that, feel free to reach out to us. I'm happy to answer any questions or try to help with that if anything's unclear. And then we will meet back here on February 21st, same bat time, same bat channel for our next session. And then we'll just wrap up here. Mariah's going to put an assessment up And if you would please just take it, it won't take very long. And then I will let you go on with your afternoon. While that session's going up, so that we have it on the recording, I'm just going to highlight a couple of slides where we have a financial assessment tool for calculating the cost of provider turnover. And that's linked on this slide here. It's a really useful tool for kind of seeing what it's going to cost if you have, say, a physician turnover or a nurse practitioner. So we do both physician and non-physician providers. And then we also have tons of resources on the STAR Center webpage. And we have some good self-paced courses, so some good e-learning courses, and also a terrific podcast that a bunch of folks at the STAR Center have been working on, and that has been spearheaded by Helen. And there's some fantastic interviews on a lot of workforce and wellness topics. And then you can also sign up for our newsletter. It's probably how you heard about this learning collaborative, but if you don't already get access to it, the link for that is here. And like I said, please just reach out to us at any time if there's anything we can help you with. And we will see you in a few weeks. And if anyone has questions or whatever, I'm happy to stick around for a few minutes, but I know a lot of folks have other things to do this afternoon, so I'll let you head out whenever you're done with the evaluation.